Most interestingly, we do not see any difference for any of the factors plateauing of there's a plateauing of national ANC rates. Without increasing coverage of effective ANC, it will be difficult to sustain the current rates of decline in maternal deaths, particularly with regard to deaths due to indirect. Slums has more than doubled in the 7 years since 2006 and exceed national rates 37% versus national 34%. Almost half of this increase has been section rates now exceed the expected 15% based on WHO guidelines in all 3 urban areas. In the slums, it is 16%, and it's excessively high in non-slums and other urban areas. While we have been discussing these high rates for several years now, since the BMMS 2010, no effective strategies to address this have been developed or implemented. Postnatal care rates have increased from 2006 levels, but are still quite low. Newborns are also less likely to receive postnatal checkup from medical agent providers than their mothers, which is the result that we see in the current survey. This should be a concern because we do want to increase postnatal care for both the mothers and the newborns. And in terms of essential newborn care, while the intent is to have this high coverage for all newborns, of the 5 essential newborn care that we picked, only less than 5% of newborns receive all, which is quite worrying. With that, I finish this part of the presentation and invite Mr. Karar tonight, us on a measure evaluation, to present the findings in child health and nutrition.
In this section, we will present the Urban Health Survey 2013 preliminary findings on child health, feeding practices, and nutritional status in urban Bangladesh. For the preliminary dissemination, here we present the childhood mortality rates in city corporation slums. This slide shows that in 2013, infant mortality rate is 49 deaths per 1,000 live births, and under 5 mortality rate is 57 deaths per 1,000 live births. This means 1 in every 18 children in slums dies before reaching their 5th birthday. Even if compared to an earlier time point like 2011 Bangladesh Demographic and Health Survey or BDHS, infant and under 5 mortality rates in urban slums are higher than the national level. In comparison to childhood mortality figures with the earlier round of urban health survey, we can see that infant mortality declined by 22% and under 5 mortality declined by 30% during the last 7 years. However, despite this reduction in childhood mortality, infant and under 5 mortality rates in slums remain much higher than the targets for 2016 set in the ongoing health sector program HPNSTP. Now, let's move on to the care-seeking behavior for acute respiratory infection or ARI among children. In 2013 Urban Health Survey, we found the prevalence of ARI to be around 3% among under 5 children across all urban domains. From this slide, we can see that care-seeking from medical facility or provider to manage ARI among under 5 children is higher in non-slums, where nearly 2/3 of children receive care from a trained provider. However, antibiotic use for ARI is higher for other urban areas, only which surpasses the HPNSTP target of 50% in 2016. In comparison to the earlier round of Urban Health Survey, care seeking for ARI among children from medical facility or medically trained provider improved only for slums between 2006 and 2013. Now, we will move on to childhood feeding practices. Here we can see that exclusive breastfeeding among children up to 6 months approached 60% in city corporation slums and non-slums, which is in line with the findings from other recent surveys at the national level. Out of the 3 urban domains, exclusive breastfeeding among children under 6 months is slightly higher in the other urban areas. During the last 7 years, exclusive breastfeeding among children under 6 months increased substantially in both slums and non-slums, more so for city corporation slums. Different food groups and age-appropriate number of times in a day. We can see that only 1 in 4 children in slums are fed with proper IOICF practices, which is lower than the national average of 32%. This proportion is markedly higher in non-slums and the other urban areas. Despite good progress in breastfeeding status, proportion of younger children fed with proper IYCF practices remain much lower than the HPN SDP target of 52% for 2016. In order to show the nutritional status of under 5 children in urban areas, we use stunting and wasting rate on the slide. This slide shows that undernutrition status is the worst among the children living in slums, where 1 in every 2 children is stunted, that is too short for age, and 1 in every 5 children is wasted, that is too thin for height. Whereas the stunting rates in non-slum and other urban areas already has achieved HPN-SDP goal for 2016, nutrition status of children in slums remain a big concern. Though wasting is considered to be seasonal, this is to be noted that the current wasting level in all urban domains exceed WHO emergency threshold for global acute malnutrition, which is set at 15%. Similar among under 5 children in slums, it worsens among children living in non-slums. Reduction in under 5 mortality since 2006, childhood mortality rates in slums remain higher than the national level. Care seeking for ARI among under 5 children is better in non-slums, improved substantially and reaches around 60% in all urban areas now. However, IYCF practices in slums remain very low. In the last 7 years, there has only been a modest improvement in nutritional status among children in urban Bangladesh, and wasting level remains unacceptably high. With this, I conclude the presentation on child health and nutrition from 2013 Urban Health Survey. Now I request Dr. Kim Streetfield from ICT-DRB to present on intra-urban differences over time.
Thank you. You've all been very heroic, surviving here for 2 hours, and we are not finished yet, but I'll try to keep this very short. My task is to just look at the question of whether equity has improved. And as proxies for poor, non-poor, we'll just compare slum and non-slum only, which is the best we can do at the moment. It seems fairly reasonable. I'll have a look at a few indicators which you've already seen. There is no new information in that. And then just have a couple of concluding remarks in the hope of drawing out in the discussion session from people who work in the field, in the ministry, and in the NGO sector and private sector, some possible explanations for what we're seeing here. So the first slide is contraceptive prevalence, and you'll see a pattern in this. It's quite remarkable. This is the only indicator that we've seen where the slums have improved from being relatively inferior to the non-slums in terms of contraceptive prevalence to exceeding the non-slums. We thought at first maybe it's a function of something else, like younger age, but it's not. We checked all that. It's not that. So it's interesting to see that there's been a dramatic increase in contraceptive prevalence use rates. Now, the pattern that I'm talking about is that we still rely, as we have done for decades, on short-term temporary methods, as been mentioned, or pills and condoms. These are available everywhere in the urban areas, pretty much in the rural areas. What's important about it is that the majority are being purchased through the private sector, which means people are able to pay or are willing to pay for that service. And this is something that we need to see in the future, because we can expect that as incomes rise, that people will increasingly be willing to pay and able to pay for health and family planning services. The next slide is looking at one of the outcomes of that rising contraceptive prevalence, which is the amazing decline of half a child in the slums in total fertility rate in 7 years. This is really quite extraordinary. And you saw earlier in the fertility section that now all of these areas are below replacement fertility. So we can expect, I think, to see in the next demographic and health survey that the entire national fertility rate has been pulled down below replacement level fertility, or close to replacement level fertility for the first time. You'll see also that the difference on the left in 2006 between 0.6 of a child between slum in the blue line and non-slum in the red line has also greatly reduced. If that trend continues, we can expect the levels in slum and non-slum to be pretty much the same in a matter of years. And that's quite surprising. There are not many indicators like that. And just to repeat, I think it's partly because it's a service, family planning services are widely available, they're fairly low cost, and people are able to pay for them. That we didn't see any other changes, as you heard, for example, in marriage, which accounts for this change So much of this change in reduction in total fertility is due to increasing contraceptive use, we think. Indicators of maternity care, antenatal care, medically trained provider, delivery by a medically trained assistant, and postnatal care. Nearly always, the differences are still very large. So, for example, the use of 4 or more visits for antenatal care, you can see the difference in 2006 was 31 percentage points. It's now 29. There's almost no change, even though there's slight improvements in both areas, but not much to get excited about there. This one is assistance function. And the final one of these is postnatal care. We see again some reduction in the difference between slum and non-slum, from 29 percentage points in 2006 down to 22 percentage points now. Still a big difference. So the use is almost twice as high in the non-slums as the slums. And the final one here, the final indicator I'll present is stunting. This is very different. And I don't think we can seriously argue that there are major interventions going on in the urban areas to reduce stunting. So there's been a very slight improvement, just as there's been slight improvements nationally. And you can see in the slums that the proportion of children stunted, that's below -2 standard deviations, has dropped from 56% to 50%, but that's still 1 in 2 children. Half of all children in the slums are stunted. And even more surprising, I think, is that 1/3 of all children in the non-slums, where families are relatively better off, are still stunted. So we've seen, even in this short period of 7 years, quite an expansion in the range of providers. So it's, in addition to the government, the NGO, in the maternity health care area, maternal health care area, we've seen that, especially with regard to medically trained providers, we still have the, as Dr. Sham said about the declining use of medical trained providers with the delivery of antenatal. By this service, if they're providing it without medically trained providers, we have to be a little careful with what the impact of that might be. The other variables, so the NGOs are offering, possibly with subsidies, they're offering considerably lower cost facility deliveries than we've seen in the past, and compared to the other providers as well, so it's pretty good. And then the issue of C-section, which is the explosion of C-sections around the country. If you've been present with any of the maternal mortality surveys in 2010 particularly, we've seen that this is really skyrocketing. And it really cries out for the government to be involved in regulation of this. It's almost a totally unregulated sector right now, and you have to ask yourself, do we really need all of these C-sections that people are getting? And do the people who really need them, are they getting them, or is it normal deliveries in some cases? So this is a national issue, but it does raise the question of regulation and how that sector can be regulated. For my last one, I just want to come back to the first presentation on the demography. We saw that in the city corporations, I know it's a little bit complicated, and at the break we were chatting about definitions of urban areas, but just focusing on the city corporations, which it's about Dhaka City Corporation is about 143 square kilometres, whereas Dhaka City is 1,430 square kilometres, 10 times bigger. The definitions and the boundaries are a little bit fuzzy once you get outside the city corporations. Within the city corporations, the slums account for 1/3 of the population, but they account for 2/3 of all child deaths. Now, what we need to be concerned about is that not only is all future growth in Bangladesh will be in the urban sector, but that the slums are growing twice as fast at the moment, twice as fast as the non-slums. So over time, we'll see an increasing proportion of urban population being slum dwellers. And if slum dwellers are at such a high risk of child mortality and probably other age group mortalities as well, then we might have a problem when we're looking at sustainable development goals in pulling under 5 mortality down further. Bangladesh has been, I think, very justifiably proud of achieving MDG4, where we got a 67% reduction in under 5 mortality in 25 years. Under sustainable development goals, we'll be looking at a 60% reduction in 15 years. So if the slums are increasing and they're such high risk, it may hinder that progress in pulling under 5 mortality down faster than we have done up to this point. And another point that I'd like to make is the same in the slums and the non-slums. It doesn't make sense, to me anyway. How can it be the same when you have 10 times higher population densities living in one? If you look at diarrhea, we know that the slums have massively higher sharing of toilets. So you might think, well, if you share with a lot more families, the risk of childhood diarrhea must be higher. When you look at it, it doesn't make any difference. If you share with 5 families or 50 families, the rate of childhood diarrhea is the same. And yet we know the mortality for children is much higher. So what is it exactly? It must be something to do with the environment. It could be malnutrition. It could be other things that we haven't picked up yet, like accidents, fires, traffic accidents, drowning, maybe. I don't know quite what it is. But I think we have a long way to go to really understand what exactly is the risk of living in a slum compared to a non-slum. Because it's not quite clear yet from the results that it's what at least I used to think it was, which is crowding, sharing of facilities, sharing of water supply and so on. So what actually is it? And then future slum growth will be predominantly in the peripheral areas, like out past Kamrangi Char and then in other areas and so on. So they won't have access to the same facilities that they have in Korail or somewhere in the middle of the city, in Mirpur or something like that. So we have to think a little bit about planning for the future for 2015 to coincide with the International Conference on Urban Health, which will be held in Dhaka for the first time in March of next year. Thank you.
With this, we have come to the end of the presentation session. All the presentations will be made available on ICT-DRB, Measure Evaluation and Reports website next week. We are now going to collect your queries on the second round of presentations. Can I ask the volunteers to collect questions from the audience, please?
Over 14,000 from the slums, over 25,000 from non-slums, and about 11,000 from the other urban areas. And I know that when we show pictures that stay in your mind all the statistics, and maybe what got stuck is Shushmita's presentation, where we focus on the slums there, because we look at some statistics, and then we just wanted to show some of the pictures behind those statistics in the slums. But all our presentations included information from all the 3 areas. We'll be happy to show you the presentation again if you missed out on something. And just to answer the questions that are relevant for my presentation, the second question was, the survey showed that in the slums, percentage of injection became widely available through the Blue Star pharmacies. This is the social marketing company's endeavor, and they were available not as much before in 2006. A lot of the injectable users in the slums used to get it from NGOs and then also from the public sector, and in 2013 we found that there has been a shift towards moving towards the private sector, and these are again mainly pharmacies, the Blue Star pharmacies. Third question was teenage pregnancy in slums remained the same over 2006 and 13. What is the reason for such reduction in fertility in slum areas? If you remember any of our presentations from the Bangladesh DHS, we have seen that in Bangladesh there is a paradox. The western part of the country starts childbearing early, but they have lower fertility, and the eastern part of the country starts childbearing later. Age of marriage is higher, but their fertility is higher. So even though teenage childbearing has remained the same, it seems like that women kind of know how many children they want, and they fulfill their needs quite early. I'll now pass into Rahim.
Asking why environmental factors did not come up as a major reason for migration to cities. Environmental factors are mainly a problem in the south of the country, the coastal belt, Odisha to be specific, which constitutes only about 6% of the population of the whole country. And what we presented today was the aggregate responses of all slum residents whom we interviewed. If we look at the responses of slum dwellers who are from Odisha, then over 50% of them reported an environmental reason as a reason for migration. But the actual numbers could be larger than that, because environmental factors can often be connected with economic factors like looking for work or looking for more earnings.
I can answer the question addressed from the maternal health
piece, the question is that quality of care provided by NGO field worker is a concern. What should be done about this? I don't think we presented data on NGO versus other providers. We present data on medical trained versus non-medical trained. And I think that's where the concern is that, if we want to have a provider expect to provide certain services, this provider better be trained to provide those services. And as we move forward, and we also start addressing other conditions, for example, in the indirect deaths, where if you remember, some of the big causes were jaundice and tuberculosis, then the issue of urine test, blood test becomes very important. And I think if that is not done, then it's very difficult to say that that is complete.
Next round of survey. There is another survey that has been conducted by Newport, and NCDs are included there, and they will be disseminating the results very soon.
Okay, this one question on is there any coordination or coordinated activities in the service of medical care providers in our public, private, and NGO sectors? So my own personal knowledge of it, which is that it's not that there is no coordination, but it is a bit. And you have the big USAID funded NGO system. You have the BRAC program, etc. So there are big initiatives that do talk to each other, do coordinate among each other, and there are large network providers like, for example, the Managed Slopes Network. So they do these networks to exist, but I think we can definitely improve on the coordination, and I think that's one of the big areas that we probably should see much more interaction happening.
Focus on adolescents and youth health, or issue of STDs, STIs, MR, etc. No, we did not ask any question on STDs, STIs, or MR. And there was no particular focus on adolescents, but we and who are not married. So we have adolescents who are married, and we have more information on them. So it's just
why are the cost of normal deliveries high in public sector facilities? And I'm going to ask Manta for responsibility.
It was a surprise to us that the cost of delivery was less in NGO facilities compared to the public sector. What we can think of is, and that's what we have heard from some of our qualitative information also, that even though some of the services are free, there are other costs associated with going to a public sector that they have to, those costs seems to be adding up, and this is information provided by the women themselves who went to the different sectors.
One question was asked on nutrition, is that why the severe wasting rates in slums and non-slums are very close at around 5.6%, and why there is no difference between
for us for a long time, because despite the changes we had in the nutrition level for last 20 years or so, the wasting level has consistently remained at a very high stage, and despite the economic development and the change in income and expenditure that we have been seeing over the last decade in particular, we have seen that wasting level is also hovering around 15% or often crossing the emergency threshold set by WHO of 15% very often. We have seen that in the urban health survey, the results showed that in all the urban domains, the rate is just above the emergency threshold, which is very worrying.
The convenience of going to a nearby pharmacy, getting the supplies for the month, where the cost can be higher. So I'm very comfortable with this trend that we see of access. There was other question was why was the BRAC delivery center, the birthing center, not included? Merging it as part of all NGO facilities, which most of the facilities tend to be much more involved. Many of the slides, because of low use, the numbers tend to be very high.
The numbers for BRAC center, and in the other slum areas and non-slum is much more, around less than 1%.
Not included in the NGO center system. So within the BRAC centers, the BRAC facilities, only the birthing huts have been treated as a separate category.
the indications are from the results that actually most things have improved. I don't think it's so surprising. I mean, there are very substantial networks already in the cities, migrations. It's one major disadvantage. You have an immediate network, you have all kinds of communication systems in place, you have advertising of the rights that you might need and so on. So it's not so surprising in the case of rural areas as well. So it's not necessarily a disadvantage. If you look at the improvements in child health over the last decade, there have been part of it is access to high quality antibiotics and things like that, and also treatment services. So I don't think it's so surprising that the trends are moving in a positive direction.
There's a question on whether there is...
Honourable Minister.